Okay, so let's take a look. I kind of cheated this morning to see what your guys' response rate was for the surveys because I was excited. You know, out of the entire quarter, you guys, I got 3 cohorts that I teach. I'm happy that you guys are the first ones I see in the morning. Like, I'm not being facetious. I'm just trying to be genuine, but I'm just not caffeinated yet.
Get it? We're the
So,
shit. It's fine.
but yeah, 100%. So thank you so much, guys, for getting those evals in. I genuinely do appreciate it, so I can, keep improving. So I will fulfill my end of the bargain. We will have a kick-ass review on Monday. Think of it almost like a practice final. So I would say, study throughout this week into next week, and then basically come into Monday ready to take the final, so you can kind of see where you need to kind of focus your last minute studying on. Okay. We'll talk more about the final after lecture. Sound good? And I'll help satiate some fears. Promise. All right. So today, I had coffee. I had gone to the office today. Usually I'm sipping an Irish coffee on this lecture because this is fun. This is fun, y'all. So again, I'll be pretty clear about like what you need to worry about. Okay, but just sit back, relax, enjoy. This is our last lecture. All right. Hey, did you know if you break a bone, it's called a fracture? These are all the different ways to break your bone. You guys get what I'm getting at here? Like, don't worry about it. This is what TSA will actually see if you have a hip replacement. Now, you guys know I'm a nerd about this, so I'm going to show you some cool surgery videos. They're all animated, don't worry. So, hip replacements can kind of vary depending on the different implant and procedure and all that stuff. What you're seeing here is somebody's hip. You notice that cartilage is really inflamed, right? So this is why we need to end up replacing it. We make a lateral incision and separate the skin, the connective tissue, the muscles. And we have finally access to the hip. Now, they make this look easy. Does anybody know how they dislocate your hip in surgery? Yeah. So they either have like one dude like pull on it and another dude hold you down, or imagine raising your leg above your head and then rotating it outwards. Y'all, general anesthesia is amazing. Mm-hmm. Mm-hmm. Ortho surgeons, they go into Home Depot and they're still thinking about their patients when they're in the power tools section. Okay, so once we dislocate that hip, we take a fancy cheese grater and we grate down the remaining cartilage so it's flat. And then this is going to be the socket. What's kind of interesting is if you notice the socket, it has texture to it. We use a special kind of cement that when we cement it into the hip, the cement actually allows it to get calcified. So the osteoblasts will lay down calcium with the cement, fusing the socket to the hip. And we just simply snip that off there. It's actually a bit of an involved process. File the inner hollow, and then there's your new joint. Cool. I'll let it play without me interrupting it for another loop here, but does anybody know how long it takes to do a hip replacement nowadays? Yeah, it's almost like drive-through status. People will go in for a hip replacement and then walk out in the afternoon. Walk out on their own free power. It's nuts. Hip replacements used to take anywhere between 8 to 10 hours. Now we can probably do it in 1 or 2, depending on the situation. For you guys as nurses, what's probably the most important thing to do when your patients, come down from the anesthesia and they're coherent? Yep. The most important thing there is ambulation, trying to get them to stand up, move around. We don't want fluids building up in the lungs or anything like that. Oh, come on. I'm on Ethernet. How is this possible? I would say from like a mental standpoint, like mental health-ish, the hardest thing about working or the hardest thing about these replacements is getting your patient to actually trust and put weight on that joint, on that new joint. A lot of them don't, and they can develop a gimp or an awkward gait if they don't actually trust it. It's weight bearing. You can totally put weight on there. Okay. Yeah. So it's kind of crazy. Nowadays, most implants are made of titanium. They used to be stainless steel. Anybody know why that's a bad idea? Yeah, stainless steel actually rusts. The reason, so it's going to rust in the human body. The other thing is stainless steel gets its quote unquote stainless properties from nickel. You guys know about nickel. You can have an allergy to it or you can develop an allergy to it. So patients were having implant rejections at one point, which sounds terrifying. Okay. All right. Hey, don't break your bone. But if you do, there are some steps here. Notice I am slowing down and writing some stuff down, yeah? You break your bone, you start bleeding. Blood starts pooling under the skin. What's that term? What do you call a collection of blood under the skin?
A hematoma.
Hematoma. Very good. So here you're bleeding. Hematoma. So you're bleeding. What do we want to do when we start bleeding? What do we want to do with that blood? We want to make it what?
Clot it.
Perfect. Here's your blood clot. Okay. Now what's going to happen here is your fibroblasts lay down collagen. They're going to start laying down collagen to kind of make a soft repair. This is called a procallus. Called a procallus. Okay. Now, what's going to end up happening is we're going to have to calcify this collagen, the scar tissue. What cells are responsible for calcifying stuff at the bone?
Osteoclasts.
Nice. Osteoclasts calcify. Oh, sorry, osteoblasts. Class breakdown. My bad. Osteoblasts. Calcify collagen. And that's going to make a callus. So one of the things is if you break your bone, it actually comes back denser and stronger because your body understands that it's a weak point. It's because of this procallus being converted into a callus. Okay. Final step there is remodeling, but keywords, procallus and callus. Okay. The problem sometimes though, is that we make too much scar tissue. So you see this person actually had a hip replacement. They started laying down a lot of scar tissue and it all calcified. So unfortunately, what do you guys think treatment is?
Amputation.
So this person had to have their whole leg amputated. Anybody know how fast it takes to do a below the knee amputation? Like how fast it takes to like cut off a leg? Pretty close, yeah. One of my friends was in residency doing his surgical rotation. His first time cut off a leg in 12 seconds. Oh, they go fast. All right. Hey, if you break your bone, don't move it. Duh. You can dislocate stuff or kind of dislocate stuff. All right. So this here, just a little bit of terminology, but hey, I would probably take notes on this too. Tendons, the way I remember this, tendons tie different things together. Tendons tie different things together, i.e. muscle to bone. That's opposed to ligaments. Ligaments link similar things together. Okay. So if I'm asking you what's the connective tissue connecting two bones? Ligament. How do we attach muscle to bone? Tendon. All right. So here's some also important terminology because you're going to come across these terms actually in foundations. A strain is damage to a tendon. So if somebody suffers a strain, it's going to cause damage to a tendon. A sprain is something to a ligament, damage to a ligament. Sorry, I have nothing for sprain. But 3 out of 4 is not bad. Okay. Has anyone ever suffered a strain or a sprain? Out of curiosity. How long did it take to heal?
Forever.
Forever. Yeah. Yeah. 6 weeks, give or take. I personally suffered an avulsion. You don't need to know this one. I'm not going to test you on it. An avulsion is when you completely tear off the tendon. I was an idiot. I was trying to friggin' longboard on ice. Don't do it. Basically messed up one of my ankles, tore 3 of the tendons. Now my feet sit like that. One of my feet sit like that. Why? Why does it take forever? Why do we see such prolonged healing time?
Because we can't really not use it.
You constantly have to keep using it. Sure, sure.
No blood flow.
Yeah. Tendons and ligaments are avascular, i.e., there's no blood going there. Oh, Lita. They sell door hinges at Home Depot. You can get a door hinge. Okay. So when you strain a muscle, hey, you just stretch it beyond its normal capacity. It's fine, but not really focused on that. You've strained your muscle. Cool. All right. So what do you do for a strain or a sprain? You rice it. Now, I don't know if it's me because I'm Asian, but that kind of, if I walked up to you like, hey, just rice it, y'all would probably look at me kind of funny too, right? So I don't know. I can't think of a better acronym, but that's kind of like the industry standard, I guess. Question for you. What's better for a strain or a sprain? Ice or heat? What would be better? Lita says both. You alternate. Yeah. So let's kind of investigate this here. What would be the benefit of ice or cold pack? What would that help you do in terms, how will that help in terms of healing? This causes vasoconstriction, leading to decreased perfusion. So you have less blood flow, therefore decreased inflammation. Okay, very good. What about on the other end? What's the benefit of heat? How? How do we promote blood flow? Heat causes vasodilation, increased perfusion. Basically, now you have more cells, you're moving product faster, but you also promote inflammation. So in reality, Lita, as you called it, ice and heat combined is best. Okay. Studies have shown that, yeah, you can have benefit from one or the other, but more studies have actually shown that if you alternate ice and heat, you'll see even better healing times. Depending on the severity of the injury, where it's at, I would say start with 20 minutes on one, and then go 20 minutes to the different one. I like to start with ice first, but that's just me. That's a preference thing. Tendonitis, you know your Latin. Eh. All right, bursitis. Bursitis, notice I'm writing a definition here. This is the inflammation of fluid sacs surrounding ligaments and tendons. Okay, so if somebody has bursitis, it's actually the synovial joint capsule. It's actually the joint surrounding all of this connective tissue. Okay, usually caused by repeated trauma, i.e., lots of use. Okay, so you move your joints too much, boom. Weird thing about bursitis is it can go septic, and it could get into your blood. Eek. So there's bursitis. All right, epicondylitis. So your epicondyle, that's your elbow. Okay. Couple of terms here. You might hear tennis elbow. That's the lateral epicondylitis. So think about anatomical position. Okay. Lateral is going to be on this side. So think of like in tennis, like a backhand. Like a backhand. You're hurting your lateral epicondylitis. Okay. Or your epicondyle causing epicondylitis. Golfer's elbow is medial. Okay, so think about in golf, you're doing a drive, you're going to be hurting the medial side of your epicondyle. That's your forehand. Okay, so understand tennis elbow and golfer's elbow just describes the location. It's not specifically related to those sports there. What I'm trying to say is, hey, can a tennis player get golfer's elbow? Absolutely. Can a golfer get tennis elbow? Absolutely. Kendall, I am not familiar with climber's elbow. What is that?
So from experience, I don't know if it was just like a term thrown around, like climber's elbow, but people say that it feels the same, like pain wise.
I'll look into it, see if it's more medial, lateral, or both, maybe. But yeah, I'm not too familiar with climber's elbow, so I'll see what I can find over break for you. All right. Rhabdomyolysis. Alexis, this is finally your topic. This is what I've been waiting all quarter to talk about. All right, rhabdomyolysis. What's going on here? Rhabdomyolysis. Use your Latin. Lysis. What does lysis mean?
Cut.
Yep, to cut. I'm going to say breakdown here just to make a little bit more sense. But to cut, to break down, myo. What does myo translate to?
Muscle.
Perfect. Muscle. Now, rhabdo refers to a specific type of muscle. Cardiac, smooth, or skeletal.
Skeletal.
Yeah. So in rhabdomyolysis, what's the big issue?
You can lose ability to like do anything really.
Your skeletal muscle is breaking down and it's going into your bloodstream. Now your skeletal muscle is made up of what? What makes up muscle? Don't overthink this.
Cells.
Cells, yes. I was gonna go proteins, but you're not wrong. Cells is fine. Cells also made up of proteins. The problem is I'm throwing a bunch of proteins into my blood. What organ is that going to complicate things for if you have more proteins in your blood? The kidneys, absolutely. So the threatening complications, this is going to affect kidney function. It could be that your colander gets so filled with kale, your glomerulus gets so filled with protein that they can't filter anymore. Okay. Now there's two types of rhabdomyolysis. Oh yeah. Oh yeah. It's all come together. Two types of rhabdomyolysis. You can have crush injury versus compartment syndrome. Now I'm just going to define these and then we're going to talk about them, okay? With a crush injury, the compartments are broken. There is no pressure buildup. Good. So in crush injuries, your compartments are broken. There is no pressure buildup. Okay. Compartment syndrome is the exact opposite. The compartments are still intact. Therefore, we see an increase in pressure. Okay. So, kind of scrolling down here, just to kind of give us a picture to look at. This is the cross section of somebody's lower leg. Here's your tibia, your fibula, and then this is your gastroc here. Notice all of your muscles are in their own little compartment. Okay. In a crush injury, what would happen is, let's say, for example, okay, assume that I'm going to go rock climbing. Okay, I'm going to go rock climbing to a canyon, and I'm not going to tell anybody where I'm going for the next week. While I'm having fun, a boulder falls on my arm and completely crushes my arm and pins me into the canyon. Again, I didn't tell anyone where I was going. You guys know what I'm referencing here? Okay. Well, if you don't worry about it. You wouldn't have to cut
Well,
your arm off with a
Wasn't there like oh, are you referencing a movie?
Yeah, it's a movie and an actual story. Kendall, you're the climber.
Well, no, I heard about this one woman in Joshua Tree that I think it was Joshua Tree. She got stuck in the canyon for like a week because she fell and like broke her pelvis, but I don't know if that's what you're referring to.
I'm talking about a dude who had a boulder fall on and crush his arm, and he had to cut his arm off with a pocket knife.
What is that called?
You're talking about 27 hours?
27 hours with like Franco, right? Yeah, yeah. So his arm is crushed by a boulder. Everything is broken. Notice all of the compartments got crushed. There is no pressure buildup whatsoever. The problem is everything got crushed, including these bad boys. So what does that mean for blood flow to my arm, to my fingers? There isn't. So you still have muscle necrosing that gets into your blood, still hurts your kidneys. Okay. Thankfully, I think his nerves were dead for the most part, but no, thank you. I'm keeping my arm. No, the other way. Oh, go ahead.
So is there a difference? Well, obviously there's a difference between true compartment syndrome and chronic compartment syndrome. Would like someone's arm getting crushed, you're saying like the compartments are completely broken, but like in my case it was chronic. But I've heard with true compartment syndrome, you have that major pressure buildup, or is this something different?
You got it. You got it. So two ways that this can happen. We're going to take a look at this gastroc muscle right here. Okay. We're going to look at the gastroc. Now, how compartment syndrome happen is that we damage the tissue. If it's all of a sudden a certain sudden trauma, like say someone like, I don't know, hits me in the calf with a baseball bat, it's going to cause this muscle to start swelling. It's going to start swelling more and more from an injury, right? So if you guys notice during this swelling, what's happening there? What's happening to the blood vessels?
They're constricting.
They're being physically constricted. They're being compressed. Absolutely. So, hey, you're still having the same issue, even though you didn't have a full-on crush injury. Okay. This muscle is going to keep expanding. So you can have it from an injury. That's your kind of true crush syndrome. The chronic crush syndrome is from overuse. So take, for example, firefighters, especially with Australian wildfire, they're carrying gear 18, 20 hours at a time. They're working their muscles over and over again all throughout the day. If you work your muscles so much, that causes the inflammation, that causes the breakdown. We cut off blood supply. So what does that mean for blood flow to the rest of my extremity? Yeah, there is none. So what do you guys think we do in compartment syndrome where we have this buildup of pressure? How would you go and relieve that pressure? We're going to go and make an incision. We're actually going to make an incision there. Sometimes there is so much pressure inside of the limb, the wound will turn itself inside out. So don't worry, just cartoons. But hey, if you're into this stuff, Google fasciotomy. When you do a fasciotomy, again, I'm just making a cut here. Notice the pressure so much that the wound actually opens. That's how you relieve the pressure. Now you're going to leave that open for a certain amount of time. We're talking about a while. And you're going to just suture it. Notice I am not closing it. If I close it, I'm going to be applying pressure, cutting off blood flow. Anybody see the problem here? Anybody want to sit with 2 giant open wounds in the hospital for give or take 2 to 4 weeks? The crazy thing about it is we have to wait for the inflammation and the swelling to go down. Usually scar tissue forms in the wound and you're left with some really crazy scars. Like they're so cool looking.
For things like this, would they like move back over it?
You might put a wound vac over it if there's a lot of drainage. Generally, the best thing they do is like kind of do air dry and they do just like a wet to dry kind of thing. Alexis, did Alexis get booted off?
No, I'm here.
No.
Here I
Oh, there
am.
she is. Sorry, I thought you were Lita.
Oh,
Oh,
yes, Madeline, I had this. I have a question about, so my surgery was done differently where they did it orthoscopically. How do they like decipher the difference? Is it because mine was chronic exertional compartment syndrome and not because it was like true emergent?
I think my guess is when they're going through orthoscopically, they were able to access one of the more superficial ones and make the cut there and still allow it to expand within the skin. In the severe cases, which we're kind of seeing like these crazy scars, it could be that multiple muscle beds have been damaged, so we had to cut through multiple compartments to kind of let it open.
Yeah, that makes sense because I had all 4 of mine released in both of my legs. So I have scars, but they're not nearly that wicked. They're pretty tiny. I got lucky.
Gotcha. Yeah, absolutely. So this is another reason why you don't, go and poke a dead whale, like a beached whale, because there's pressure in there. But yeah, finally got to it. Sorry to make you wait all quarter. All right, so talking a little bit about your bones. For me, 2 parts. You have spongy bone and you have compact bone. Notice, where do we find spongy bone? Where do we find spongy bone in the bone?
It's more internal.
It's definitely internal. Do we find it throughout the entire bone, in the middle, in the distal ends?
The tips of it.
Perfect. Spongy bone at the distal ends. Then we see compact bone at the medial kind of sections. Okay, so if you notice, our bones are hollow. Why?
Marrow and blood.
Yeah, it's a great storage compartment for bone marrow to make blood. Absolutely. It also helps kind of reduce weight. If you had solid bones, you and I would probably be 200 pounds heavier. Okay. Keep this in mind, that spongy bone is only found in the distal ends, because we're about to get into some pictures that really bug me. So moving to osteoporosis. Osteo, talking about bone. Osis, this is a condition of. What's pores? Think about like the pores in your face. What's a pore?
Holes.
Perfect. It's a hole. Okay. So osteoporosis, the condition of developing holes in your bones. Okay. It's very poorly mineralized bones. So between osteoclast activity versus osteoblast activity, who is more active? Which cells would be more active in osteoporosis? Mhm. Okay, so your osteoclasts are getting out of control here. Your blasts are less active. So don't worry about the density ranges, not looking at that. Okay, just understand there's a progression. First, we start with your typical bone. Then we have osteopenic bone, i.e. your bone starts lacking. Osteoporosis is a step further, and now we got these holes. Okay. So demonstrated by a reduced bone density, imbalance of reabsorption. Talked about osteoblast versus clast. Cool. Bone histology is usually normal, but it lacks integrity. What this kind of means, bones keep their shape, but lose density. Okay. They kind of keep their relative shape, but they end up getting a little bit more hollow on the inside. Okay. All right. So taking a look at this picture, I don't even really know what it's trying to portray here. I have beef with this picture. What's wrong with this picture?
Look at all that spongy bone.
What the hell is that? Get out of here. That should be cortical bone or compact bone. Very good. Okay. So osteoporosis mainly affects, let me say, osteoporosis mainly affects spongy bone. So will we see these holes opening up in the medial section? I.e., you have to worry about osteoporosis in the distal ends, and it's the distal ends that are becoming more fragile. Okay. So some potential causes include decreased levels of estrogen/testosterone, i.e., decreased sex hormones. Now, there's not a clear link between your sex hormones and your bone density. There just seems to be a correlation. Okay. So let me kind of draw this graph here. You don't need to memorize this graph. I'm just using it for kind of explanation means. Here on the y-axis, we have bone density. On the x-axis, we have age. Okay. Now, I want you to think, when you are first born, right when you pop out of the womb, high or low bone density? Oh God, yes. If you came out with a fully formed calcified skeleton, you call your mother and you apologize. Okay. We all start with very low bone density. We're all kind of sacks of cartilage. Through the younger years, we start increasing bone density. So let me kind of do it this way. We start increasing bone density. At this point here, let me do a little bit more to scale, sorry. At this point here, we kind of hit puberty. What happens to sex hormone production during puberty? Oh, by God, have you met a teenage boy? Skyrocket, okay? After puberty, we still see an increase, but notice we just increase less, okay? Now, for here, this is males. Males typically hit max bone density and between the ages of 25 to 30. Again, you don't need to know this number. This is just me being a nerd, okay? Males typically max out between 25 and 30. What happens to testosterone production in males after this? Yeah, as I kind of get older, I start making less testosterone, so it goes back down, okay? Now, females, same thing. Okay, I'm just gonna right below here. You guys hit puberty, it skyrockets, absolutely. However, females peak anywhere between 20 to 25. Does
I
that
have a
age
question
range?
for you.
Yeah,
Is there, I've heard that there's a link to osteoporosis in women taking birth control.
yeah, I heard about that too.
Like, is
It's
that
like
even true or?
that, I don't know. I don't know enough about the pharmaceuticals behind it.
Yeah,
With the birth control, artificial hormones, it would make sense for bone density to go up. But again, it's not that your sex hormones directly control bone density. It's just the amount of sex hormone you make is pretty correlated with your bone density.
okay,
So short of it, I don't know.
okay.
Definitely do your research though of anything that you're taking before you recommend it to a patient. Mhm. Great question. So 20 to 25, that age range sound, I don't know, familiar to some of y'all? So you might be at your peak bone density right now. This might be the densest your bones are ever going to be. Because what do you get to look forward to after this? Oh God, that's all downhill. It's all downhill. Oh, what happened there? Why did bone density just all of a sudden tank?
Is it because of menopause?
Because of menopause. Yeah, yeah. Because during menopause, what happens to estrogen production? It tanks, it's gone. So what I'm trying to say here, who is the most at risk for osteoporosis? Who is the highest risk population?
Older women.
Post-menopausal women have highest risk. Oh yeah, absolutely, Rivka, Kendall. Dude, that blows. How do we prevent it? So let me say, what kind of exercises can we do to maintain bone density? How can we prevent or slow this loss? Nice, nice. You guys are right on it. So in terms of decreased activity levels, use it or lose it, but impact and weight bearing activities maintain density. Okay, so impact and weight bearing. What do I mean by this? Impact, I'm going to say like MMA, martial arts. Okay, now I'm not saying to recommend 83-year-old Ethel who just had her hip replaced to join the octagon. Okay, not that kind of impact, but small things like even just walking. Did you know when you walk, each time your foot hits the ground, you put 1.5 times body weight through your joints? Take your body weight, multiply by 1.5. That's each and every step. When you run, it can be 3 to 5 times body weight with each step. That's a lot of impact. Who's walking a lot? Who's probably running down the hall a lot?
Gonna be us in the future.
Nurses. So, hey, body weight support and things like that can actually help you maintain your bone density. Okay. But things like swimming, cycling, yeah, those are the two that are coming to mind. Great exercise, great for your cardiovascular, but is that going to be great for your bone health? No. Okay. So just keep doing you, yo. Okay. Obviously get your vitamin D, live in Colorado, get some calcium in there. Sound good? So it doesn't have to be so dramatic, but I'm trying to like give you some life tips. So postmenopausal osteoporosis, again, that's the #1 risk. So let me just say postmenopausal is the #1 risk factor. Okay. Don't do steroids. Don't get old. It can happen to different parts of the body. All right. So there's your osteoporosis. This is in the vertebrae. Notice this bone here is healthy bone over on the right. This is orthopenic bone. Notice your spongy bone, those holes are getting bigger. That's why it's called porosis. Okay. Now, one thing you might see is sometimes the shape of the bone might change a little bit. What do you notice is happening to this vertebrae in particular? Yeah. The ventral region is getting narrower, especially compared to the posterior. It's supposed to be pretty even. It's supposed to be pretty even, but it's not here. What's going to happen then if the ventral region starts getting a little bit more narrow? What will that do?
Kyphosis.
Kyphosis is going to cause you to hunch. Absolutely. So great. You even introduced it. Careful here about the terminology. Okay. You have kyphotic versus kyphosis. Kyphotic versus kyphosis. Okay. In a kyphotic curve, this is the quote unquote normal curve of the thorax. Anytime we add osis to the end of it, what does osis mean?
A condition of.
The condition of or a disease, absolutely. So if somebody has kyphosis, this is a condition of this curvature, i.e., we see an exaggerated curve at the thorax. Okay. So you want to say, hey, patient has kyphosis. Back in the day when we were a little bit meaner, you might also have heard it as hunchback or humpback of Notre Dame. Okay. Don't say that anymore. Just saying this is the old terminology here. Okay, kyphosis. So this can happen in your thorax. This can also happen in your lumbar. You have lordotic. This is the normal curve of the lumbar. Okay, versus lordosis. Okay, lordosis again is the exaggerated curve. The way I kind of think of lordosis, I call it the Instagram butt. You know what I'm talking about when girls try to do a selfie and they try to get their butt in the picture? The Instagram butt, that's lordosis. Exaggerated curve of the lumbar. Okay. All right. So patient here is exhibiting what kind of condition?
Kyphosis.
Mm-hmm. It's going to be your kyphosis. What kind of curve do you have?
Kyphotic.
Kyphotic. Absolutely. If you notice here in the lumbar section, your lumbar section is supposed to be kind of concave. This patient's a little bit more flat. So what curve has the patient lost?
Lordotic.
Yeah, you don't lose a disease. You don't call it a loss of lordosis. You would say a loss of the lordotic. Very good. Okay. So a little bit of humanity here. Ugh. When you guys are nurses and you're working with old people, let me tell you, old people are my favorite type of people because they are straight with you. They will tell you if they don't like you. Okay. One of my biggest pet peeves in medicine are when people treat old people like they're children. They talk down to them. Personally, if I'm an old person and someone's calling me hun all the time, I feel very uneasy. Like, I ain't your hun. Okay. I ain't your buddy guy. So real life story here. My grandmother, she was in a memory unit because she had bad Alzheimer's. She ended up getting osteoporosis. Okay. Her spine wasn't nearly as curved as this, but one of the other patients, their spine exhibited pretty severe kyphosis. And I remember one of the people there, I don't know who, if there was a nurse or a CNA, they were talking to this person just like, oh, come on, sit up straight. Just sit up straight. I know you can try it. Have you tried harder? Just sit up straight. Just try for me, please. Can you please do it, please? Okay, how is that so fucked up? That's a person, not a dog. That's a person that's lived double anybody's lifetime there that was on the staff. Okay. They deserve respect. Bottom line. People deserve to be treated like people. Now, you guys, I'm going to ask you why. Why can't this person that you're seeing in this picture, why can't they sit up straight? Why is this not a matter of willpower?
Because
they're, sorry, go ahead.
I was just gonna say their spine actually like now formed that way.
Exactly. Going back to look at what happened to the osteoporosis. Okay. That is as straight as the person can actually erect their spine. So just a little bit of humanity there. Just treat people like people. Yeah. All right. So we talked about anterior, posterior, ventral, and dorsal kind of curvature. What about scoliosis, medially and laterally? So you don't need to take notes on this. This is just fascinating to me. So this is a patient with pretty severe scoliosis. Ideally, oh yeah, I'd be pretty peeved by that too. Ideally, surgery is kind of a very last kind of resort here. What we're going to end up doing is we open up the back, we snip one of the prominences. This is a scoop to take out bone marrow, just to kind of clean it a little bit here. And then we're going to clip that opening to make it a little bit wider to fit our instruments. Scoop out the soup. Now this here, I believe, is a probe of sorts where we're trying to figure out how deep we can drill. Okay, now we drill and bore all the way into the vertebrae. We measure how deep did we drill. Okay. Here we're just kind of rounding off the edges, so there's no sharp edges there. And now we're going to cut threads. We're going to cut teeth into the hole. Why would we need threads? Why would we need teeth? Well, for the bolt, of course. That's why we measured the depth there. We're going to physically put a bolt into the vertebrae.
What's the degree of curvature that your spine has to be at for this surgery?
Oh, I don't know. That's definitely a surgeon question because like you have to think about age and development too.
Yeah.
Basically, you're gonna be doing this right here. Congrats, you are not even halfway yet. If
I
you
used to work
ever,
in a chiropractic clinic, and this, I've seen so many people that got this done that really, because like we see x-rays beforehand and afterwards, and sometimes people get this and it like completely fucks their back up real bad.
yeah,
If
anybody
it's
ever have
it doesn't
braces?
here.
Just pull on it, pull it straight, real quick. Yeah, absolutely. It's going to it's such a decision to go with back surgery, especially something like this extensive, because congrats, guys. You have officially hit the 50% mark, because guess what? You get to do it all over again. These surgeries, we're talking about anywhere between 10 to 20 hours. Okay.
I had a friend in high school. She got this surgery done. She was on the cheer team with me, and her recovery was horrible. She was out for a long time.
Yeah, let's actually go down that road here. Why? Why is this such a hard recovery? Okay, think about it. We're opening up the back, right? How do patients mostly rest in the hospital? So I can't lay on my back as long as it takes to heal. Now, in your back, is there anything important? Muscles, nerves, connective tissue. Okay. After we go through this kind of crazy surgery, you guys saw that whole memory wire get placed in. I am fusing the entire spine. Which means, what does that mean for like bending or twisting? Oh, it's very, very limited. Alexis, would you attest to that? Yeah, we're fusing the entire vertebrae. Okay, they're like poor Zoolander. They can't turn left, but they also can't turn right. You have to relearn how to walk. You have to relearn how to balance. You're on bed rest for so long that your muscles atrophy and you wouldn't even have the strength to, even if you could. Okay. Oh, ooh. Yeah, I don't know. Like back surgery is such a gamble. So why would someone ever do something like this, right? If you guys noticed in the beginning of the video, the spine was so curved. My guess is this one was so exaggerated that the floating rib was very, very close to one of the organs, either being the liver if it's on the right side or maybe a lung if it's on the left. That if this person sneezes too hard, their floating rib might pierce their organ.
Wouldn't it be safer to just remove the rib? Like,
Probably. I
I
don't
don't know.
No, that's a great idea. You'd think. But you know, the reasons why people will get this done, breathing issues, GI issues, just quality of life. With back surgeries, it is such a gamble. You're looking at, you know, maybe 50%, maybe this could actually help you. You know, and some people aren't just that much pain that and desperation that 50% is a shot that you're going to take.
It's crazy though, because afterwards, more often than not, I worked in passive side of healthcare for like 4 or 5 years and doing like modality therapy with laser and heat and all of that stuff. And I've seen some patients like absolutely miserable from surgeries like this, like total regret that just made their life so much worse. But it's a gamble, like you just don't know.
Exactly.
So beforehand too. It sucks. It's crazy.
Generally, we don't like to do this to kids because they're still growing. Usually try to wait until they're done growing, but man. So the other things I think about too, like as I kind of see this stuff, who the hell came up with this procedure? You know, like two surgeons just hanging out at a bar. Hey, Greg, I heard your dog has scoliosis. You mind if I borrow him for the weekend? Like what? I mind. Oh, Greg, that's funny. I was throwing a random name out there. I wasn't trying to target you. Sorry, bro. All right. Osteomalacia, you guys remember that soft bones. Osteomyelitis, wink, wink, nudge, nudge. Hey, caused by staph. Staph lives on your skin. how the hell does it get inside of your bone? How would it get inside your bone?
Does it have to get into the bloodstream somehow?
It can be in the bloodstream. And if I have bacteria in my bloodstream, what's that called?
Is it caused by compound fractures that protrude from the skin?
Mhm.
Or
So if it's
sepsis?
bloodborne, i.e., yep, sepsis. So it could be that the staph is already in the blood, or it could be exactly that open wound, that compound fracture. Okay, i.e., I break my bone and my bone is sticking out of my skin. It's probably a great time to go swim at the beach. No. Okay. So the problem with osteomyelitis, well, actually, let me start off here. What's wrong with this picture?
A damn spongy bone is everywhere again.
Right. Why did they draw it that way? Why? We're better than this. We
Just
live
to
in a
piss
society.
you off.
It's fucking working. All right. Well, sorry. Bone anatomy aside, the problem with osteomyelitis, this inflammation of the bone, is that we see rapid growth. So this infection actually grows very, very rapidly. Why?
Is it because of the blood supply from bone marrow?
Exactly. Your bones make blood cells, makes your blood. Absolutely. High nutrients in there. Bacteria gets in there, it's going to have a heyday. Okay. So big issue here, necrotic bone. Treatment wise, let's get honest here. That's somebody's kneecap. That's somebody's knee. What do you guys think in terms of treatment? Band-Aid gonna fix that? Fix that? No, it's all necrotic. We got to cut it. Okay. So again, just be careful. Osteomyelitis, super, super aggressive. All right. Let's see. You guys want to keep going, or you guys want to take a break? Strong votes, either party. I'd like to hear some defending remarks.
I mean, I feel like it's a chill day, so I don't really care.
Okay. Cool. How about we get through joints and then we'll take a break. Okay. All right. So joints, the only real structure I need to worry about is the articulating cartilage, the articular cartilage. It's this thin layer of cartilage in between your bones. Why do you need that there?
Prevents friction and the bones rubbing.
Yeah, perfect. Prevents friction. We do not want bone on bone action. Okay. So when we get down to it in terms of joint disorders, there's inflammatory versus non-inflammatory stuff. Really, there's only one non-inflammatory joint disorder. So here we go. Osteoarthritis. Osteoarthritis is the only non-inflammatory joint disorder. So because it's non-inflammatory, does my immune system play a role in this? Okay, that's what I'm trying to say. There's no immune system response. Or let me say not caused. Nah, sorry. Better definition, sorry. Not caused by the immune system. Okay. So the issue is I start losing my articulating cartilage. Okay. Can be caused with age, use, joint trauma. This slide is what I've been waiting for all quarter. You want to know why my handwriting sucks? It's because I have osteoarthritis in my right hand. So thank you guys for being patient with me all quarter. I've been trying to write nicely. Okay. But yes, I have osteoarthritis in my right hand. Basically, I've lost a lot of the articulating cartilage in my fingers specifically. Turns out, when you're a kid, punching bricks is a bad idea. Don't do it. Just don't.
Did you
It
just
was
do
for
it?
martial arts. Again?
I asked if you did it for fun, but you just answered that you did it for fun.
No, it was for martial arts. I used to be into breaking, not like dancing because that'd be actually cool, but like breaking stuff. So that's why my right hand sucks. I'll tell you, there is stiffness. My days of my days of being a hand model are way behind me. Okay, and limited motion. Okay, so basically, hey, I have bone rubbing on bone. That's gonna hurt. That's gonna limit my mobility. Okay. Again, not caused by the immune system. Rheumatoid arthritis, now we're getting into the inflammatory disorders, okay? So we know it's caused by the immune system. It's an autoimmune disorder. If it's an autoimmune disorder, what kind of hypersensitivity is it?
2.
Nice. This is a type 2 hypersensitivity where we are targeting our joints. So, hey, my immune system is going to target and attack my joints. Yeah, don't worry about the last point there. So again, rheumatoid arthritis, big things here. Your immune system is attacking your joints. So what would my joints look like if I had rheumatoid arthritis?
Maybe red, swollen.
Red and swollen. This is why with the rheumatoid arthritis, they almost seem like bubbles, like capsules in their joints, because the immune system's causing that inflammation, causing that scar tissue buildup. Very good. Okay, another inflammatory joint disorder here is ankylosing spondylitis. No, you'll never have to spell it, but it's a stiffening and fusion of the joints. Okay, you guys remember that surgery video of the scoliosis? That's what's happening to somebody's back here with ankylosing spondylitis. Okay, what ends up happening is it's a type 2 inflammatory disorder, so it's still autoimmune. The problem is I attack the cartilage. I attack the cartilage. And if my immune system attacks it, what do I lay down afterwards?
Would it calcify?
Yeah, that scar tissue, that collagen calcifies, fusing the joint. Okay, so definitely affects the back. Typically it happens in the back, but just think about that surgery video. Okay, lower back pain, stiffness, pain, and restricted motion. So kind of walk you through a little bit here. Notice your spine has these little discs. My immune system acts up and attacks these discs. That causes inflammation. That causes scar tissue to get laid down. Then my osteoblasts calcify this scar tissue. That's how your joints begin to fuse. Okay, so this patient here, how would you describe their posture in terms of the curves? How would you describe this posture?
Kyphoid?
Yeah, I would say they've probably, let's say this hunch right here, I'll say it's still got some, I'd say it's a little bit more exaggerated, probably. So I would say there's your kyphosis. Yeah, I would say it's exaggerated, so that's why it's a little bit more with kyphosis. What about the lumbar? What happened there? Loss of what curvature usually happens in the lumbar?
Lordotic? Lord.
Got
is
it.
that it?
Yeah, you got it. Loss of the lordotic curve. Mhm. All right. Gout. Gout is an inflammatory joint disorder. Basically, uric acid builds up. You guys remember what kidney stones look like? Those spiky balls of death? Now, I want you to imagine those kidney stones in your joints. How's that feeling? Crunchy, pokey. These sharp stones, these uric acid stones, are stabbing the articulating cartilage, stabbing the tendons, the ligaments, the joint capsule. Okay, so gout is like kidney stones, but in your joints. These crystallize and get deposited in the connective tissue. That's going to cause gouty arthritis. All right, a little bit of an FYI here, just for your information. Gout sucks. Okay, thankfully I don't have gout, but anybody who does have gout, you kind of know what I'm talking about here. Too much uric acid. It can be from diet, it can be genetics, can be medication, can be liver issues. The problem with gout is these stones form in the joints and then they can disappear. That means random days, these stones can come out, your life can be abject hell for a week. Then they go away for 3 days and then you're back in the gauntlet again. Okay. So that's what's difference between gout stones, like uric acid stones, and kidney stones. Kidney stones, once you get them, you know they're there. But with gout, they can dissolve back into solution and just pop back up again. Eh, eh, eh. Okay, disuse atrophy, you guys know this. Hey, use it or lose it, right? Things like bed rest, trauma. If you're not moving, you're losing muscle mass. Alcohol can be abusive or can be destructive to your muscle tissue. Bone tumors, we talked about it all the way back on day 2. You guys remember that? You remember the golden days, the good old days? You saw that skull with the spikes and the eyeball. Yeah. All right. So this will be integumentary next, but we'll take a good break here. Integumentary is going to be feeding into a little bit of what you've learned in health assessment, a little bit more of the whys behind it. So let's say like 10 minutes, so 9:40, we pick back up again, okay? Let me know if you need me to go back or re-explain anything. What was I looking up? Oh, climber's elbow. That's right. I'm going to look up climber's elbow. Hopefully these like they're just like interesting. Kendall, I did look it up. Climber's elbow is just another name for the medial epicondylitis, i.e. golfer's elbow. So pretty similar. I think it's caused by two different reasons though. With the golfer's elbow, the drive, the impact is what's hurting the epicondyle. With climber's elbow, it's the flexors that cause it. So kind of end in the same point, but two different routes to get there. At least that's what I saw. All right. So getting into the Integ stuff. Okay. All right. Your skin has layers to it. Didn't know if you knew that. Okay. Your epidermis, epi, that's just above the dermis. What do you guys remember? What do you guys know about the epidermis? Yeah, no problem. Is it thick or thin? Let's start there. Your epidermis, thick or thin?
And
Pretty thin. Okay, in fact, it's the thinnest layer. Do you have blood flow going to your epidermis? No, it's just the collection of dead skin cells, right? So it's actually avascular. Okay. Your dermis, in comparison, is the thickest layer. Okay. And there are a lot of structures in there. Let me say structures. Okay. What kind of structures do you find in your skin? What kind of bits do you find in there?
Sweat glands,
Sweat glands, absolutely. What else?
hair follicles,
Nice. What else? And I hope your skin's warm. Why would your skin be warm?
adipose tissue,
That's the next one. That's the hypodermis. Carries fluid, the most important fluid in your body.
Vessels.
There we go. Blood vessels. Okay. Nerves. So sweat glands, hair follicles, blood vessels, nerves. There's even muscle in there, the erector pili, but not a major focus. The hypodermis. Now you can call it the hypodermis, under the dermis. Most people don't. In the medical field, you call it the subcutaneous. More often than not, you're going to abbreviate it as sub-Q. Okay. And what is your subcutaneous made of?
is that adipose tissue?
Yep, there you go. That's your adipose tissue. Okay. So those are the three layers you're going to be concerned with. Okay. So here's a nice little picture showing you your epidermis, top layer there, it is avascular. As opposed to your dermis, thickest layer, there's blood vessels, nerves, sweat glands, everything in there. Then you got your fat. Okay. All right. Hey, these are things that come out of your skin. Wow. This is actually kind of cool in terms of wound healing. You're going to learn about granulation and kind of things like that from foundation, but someone actually did a pretty cool time lapse here. So you can actually see the different layers at work, making new cells and kind of pushing up from the bottom towards the outer layer. Kind of cool. Your skin does that.
My boyfriend did that recently. He is a dumbass and sliced the bottom of his foot really bad. We were at the hot springs in Glenwood and he was a little drunk and scraped it on the diving board. And he took pictures every day of his wound healing so he could do like a time lapse thing like this.
Oh, that's crazy.
Yeah,
Well,
and
the link's
it's
there.
really cool to watch because it was a super deep cut.
Absolutely. And like you can kind of see like the skin pulling together and the cells coming up and like flaking off. Absolutely. There's a link there if your boyfriend wants some inspiration.
Yeah, I'll tell him to send me the pictures, Madeline, so you guys can see it because it was a really, really bad cut. He fucked himself up.
Ooh. But you know what's crazy about all that though? Does your brain need to be aware of what's going on here? Not really. This all happens subconsciously. You don't even have to think about healing a wound. Okay, so some vocabulary, but you've already learned this vocabulary from health assessment, and I take a much more simplified approach to it. Okay, so in terms of the vocabulary, just the ones in red, don't worry about it because I list them out here. Okay, a macule is usually flat, usually round. What am I talking about? What is another name for a macule that's flat, round? Sometimes there's color, sometimes there's not.
Freckles?
It's a freckle. Okay. The papule is elevated, so it's a little raised, usually kind of round. So there's like a diameter, so it's usually round. What's usually round, raised, usually darker?
A mold.
Mole, mole,
Mole, mole, mole.
Guacamole. Love that humor. All right, a vesicle. A vesicle, again, is round, but it's filled with fluid. You get these when you wear the wrong shoes when you're out at night partying with the friends. What am I talking about?
A nice blister.
It's blisters. Okay. And then an ulcer. Okay. Talked about plenty of ulcers. It's just a hole of necrosis. You good? All right. Now we're getting into pressure ulcers, also known as decubitus ulcers. Heads up, I like saying decubitus, and I can actually spell decubitus. You'll probably see it as decubitus ulcers. Okay. But yeah, just also in other classes, you probably refer to it as decubitus ulcers as well. Pressure ulcers are caused by pressure. Duh, right? These right here are your risk factors. Okay, let's think about this. How does pressure cause an ulcer? What's the mechanism there? Think about the underlying pathway for this entire quarter. How does pressure cause an ulcer, cause necrosis?
Ischemia.
Yeah, pressure causes ischemia. So if you're sitting on your butt too long, the blood flow is not getting to your skin. Hypoxia, which leads to your necrosis. That's your ulcer. Okay. Shearing forces, it kind of makes sense if you're moving or pulling on the skin. Okay. Friction, we kind of talked about this here. Friction on your skin, too much friction is bad. Moisture. What does moisture do to your skin despite being the essence of beauty?
Makes it soft.
It softens the skin. Okay. Why would a patient be exposed to constant moisture?
Pee.
They're incontinent, absolutely. If they're kind of sitting in their own urine there. Okay. All right, we're going to come back to this slide here. But hey, pressure ulcers. You guys talked about them in health assessment, but we're going to be kind of talking a little bit more on the patho side here. So your pressure ulcers, your decubitus ulcers, they come in different stages. The higher the stage, the more advanced. So stage 1 is pretty, recent. Stage 4 is pretty advanced. With stages, you guys as nurses will not be staging ulcers. Okay, staging ulcers are a medical diagnosis. You're going to learn in quarter 2 about nursing diagnoses, which are a little bit different. Okay, so what I'm saying here, I'm going to talk about it in stages. Just understand if a patient has a stage 3, stage 2, what am I talking about? Because that's how the charts are going to read. Okay, so in a stage 1 ulcer, this is the most early one. Let me ask you guys, which layer of skin is affected in a stage 1 pressure ulcer?
Epidermis.
Epidermis. Well, let's think about this. And this is why I'm trying to hint at this. Pressure ulcers, decubitus ulcers are caused by pressure, right? Can you experience ischemia at the epidermis? Why not?
Because there's no, it's avascular.
It's avascular, there's no blood flow. So this is what I'm saying is very tricky, and a lot of students get this wrong. Okay. In a stage 1 pressure ulcer, yes, it's the first stage, but it is not the first layer of skin. What layer of skin did we talk about is vascularized?
The dermis.
Okay, so this is what I'm getting at. Stage 1 is going to affect, let me just put down here, the dermis. And that's what's weird about this. Your dermis is becoming ischemic, hypoxic, starting to necrose. Your epidermis, the top layer, it's still intact. So in a stage 1 pressure ulcer, would you have an open wound? No. Okay. The way I kind of think about this, like think about like a satellite photo of a house. Okay. You can only see the roof, but right now the foundation is rotting. Okay. It's only when the foundation completely rots do we go to a stage 2. Only when the foundation completely rots does the roof fall in. So in a stage 2, it's going to affect the dermis, and now the epidermis is going to fall in. The only way for the epidermis to fall in, let me see how I can phrase this. Okay. What is the state of the dermis in order for the epidermis to completely cave in? What is the state of the dermis? Think about your foundation. If your roof is going to fall in, what does that tell you about your foundation?
Starting to necrose, or it's necrosed.
Yeah. So by the time we get to a stage 2, the dermis has already began to necrose. In order for your epidermis to fall in, there has to be no dermis. So in a stage 2 ulcer, in a stage 2 pressure ulcer, do I have blood vessels there? Sweat glands? Nerves? Tissue? No, it's all necrosed. Okay. So in a stage 2, it goes dermis, epidermis. Now stage 3, we see adipose tissue. That's because the dermis, the epidermis is gone. Okay. Stage 4, what's underneath the adipose tissue? What's left?
Your muscles.
Bone / muscle, yeah. Depending on where it's at. Okay, adipose. Actually, sorry, I shouldn't say adipose, I should say sub-Q. Kind of keep with the theme of what we've been talking about, sorry. Okay, so I'm going to tell you, decubitus ulcers, huge point. You're going to be getting a question, you're getting at least one question on your quiz and at least one question on your final about these. Okay. Just because these are so serious. A little bit of context here. Does anybody know how much it costs to heal a decubitus ulcer? Anywhere between $500 to $20,000 for one wound. Okay. Cost of the US market, the healthcare facilities, anywhere, we're talking about billions of dollars a year. Why is this so important? Are these preventable?
Yeah,
How do you prevent these?
turning patients and changing them and all of that.
Frequently turning patients, changing them, making sure they're not sitting in their urine, etc. Okay. So a couple questions about this here. At what stage do we have an increased risk for infection? At what stage do we see an increased risk for infection?
S2.
Stage 2, yeah. Stage 2, we see an increased risk of infection. Why?
Because it's the first time that the epidermis is open. It's an open wound now.
That's exactly. At stage 2, now it's an open wound. Very good. All right. Let's think about pain. Would a person experience pain or sensation? I should say pain / itching. Would a person experience pain / itching with a stage 1 pressure ulcer? Yes. Why? Yes is the correct answer, but why?
Because it's the dermis that's damaged, and that
What's in the dermis? What's in the dermis to cause
all
pain
of
or
the
itching?
things. You have blood flow and nerves, all that.
Your nerves, exactly. So in a stage 1, yes, your nerves are suffocating. They're sending out their dying message of saying like, hey, I'm dying. That's your itch. Okay. What about a stage 2? Would you experience pain or itching at the ulcer? In order for the epidermis to fall in, what do you know about the dermis?
It's exposed.
Not just exposed. What's the state of my foundation if my roof falls in? Yeah. In order for my roof to fall in order for my epidermis to fall in, we know that the dermis is completely rotted away. There is no dermis. That's why the epidermis falls in. If I don't have a dermis anymore, would I have nerves to feel? There's no pain here. Very good, Kendall. You got it. What about stage 3? Adipose tissue. Do you got nerves in your adipose tissue? Oh, not really. Okay. Stage 4, it can be a maybe. It can be a maybe depending on where it's at. But take, for example, feel your lower back, feel your sacrum right now. How much muscle do you got back there? That's going to go straight to bone. So, pressure ulcers, 100% preventable. Anything past a stage 1, you wouldn't know that it's happening because you can't feel it. I'm going to explain this a little bit further here, but understand this is what makes decubitus ulcers so dangerous. They cost a lot and they're 100% preventable. The problem is you don't know if it's going on or not. Okay.
We just had a patient at work who needed a hemicorpectomy because he was a para and his like everything was basically gone. It was the deepest wound I've ever seen and the craziest smell I've ever smelled. But he was living alone in his apartment, so he really wasn't caretaking. and able to caretake or have people come for him. And so he literally had, half of his body cut off.
Yeah, absolutely. And like, let's think about this. Was he screaming in pain when you brought him in? No,
Mm.
absolutely. This is what's crazy about decubitus ulcers. Okay. So here's a stage 1. Okay, be honest with me, guys. If you saw that on a patient, would you worry? Dude, that looks like nothing. That honestly, that looks like a freckle or maybe like some sort of abrasion. That doesn't look like anything. But at this point here, you know that the dermis is suffocating. At this point, you know the patient's going to feel itchy. That's your pain sensation. That's the only time in which you can catch these. Let's say you don't catch it. Now we go to stage 2. Again, why did my epidermis fall in? Why is it an open wound now?
Because you lost your epidermis due to the
Yeah.
pressure.
Yeah, you got it. I've lost my epidermis and I've lost my dermis at this point. So if I touch, let's just say, for example, this part of, that doesn't show up, does it? If I touch inside of the wound right here, there's no nerves. I can't feel that. But I want you guys to use your assessment skills. Take a look at the area surrounding the ulcer. How would you describe the surrounding area?
It looks like a stage 1.
Well, it looks like a stage 1, absolutely. How else would you describe it?
Is it dry? Maybe itchy?
Uh-huh. I would say it looks extremely dry, maybe a little bit itchy. You guys are both right. Noe, this is a stage 1 ulcer on the outside. That surrounding tissue is also dying, also making it itchy. It looks pretty red and inflamed, right? Hey, what's a patient going to do when they feel itchy? Why is scratching such a bad idea at this point?
You're going to tear into it more and cause infection.
Absolutely. That's one of the reasons we see the increased risk of infection. Okay. Stage 3. What's that white stuff that we're seeing now? It's kind of like a thin film of it. What's that white stuff? Yeah, adipose tissue. Absolutely. Again, I have no sensation in here. The surrounding tissue maybe, but no tissue at the ulcer because the dermis is completely necrosed. The nerves are necrosed. All right. Stage 4. Oh my God, you can almost smell this picture. Okay, to help kind of orientate you, here is the sacrum. This is the ischial or iliac crest. That is butt cheek 1, butt cheek 2, scrotum's down there. Okay, so you're looking at the patient's lower back. Why? So answering the question here, why do we see pressure ulcers develop on the sacrum, on the ischial tuberosities, on the iliac crest? Why these areas?
Bony prominences.
These are the bony prominences. Very good. Okay. When you have a bony prominence, that's like a specific area of concentration. We're increasing pressure at that area. Now, can this patient feel that this is happening? Maybe around the wound, but not in the wound. Okay. So Ashley, a little bit of a tie into your story here. How on earth does somebody let this happen? How does this even happen? So a little bit of a story. Woman down in Florida woman. She was a single mother, had one son. Son grows up, goes to college, moves to a different state to start his family. She's kind of by herself, right? Depression begins to set in for this poor woman. She becomes horribly depressed. She ends up resigning from work and she just stays at home. She stays at home and watches TV all day. Her depression got so bad that she stopped going out of the house, stopped getting groceries, stopped doing anything outside of the house, just sat on the couch. At one point, her depression got so severe, she stopped getting up to relieve herself. She would urinate and defecate into the couch. Son doesn't hear from his mom for a couple of weeks, kind of gets worried, calls the first responders. They show up. She's alive. She's on the couch, but she has such bad ulcers from the moisture, from the infection. The cubitus ulcers are so bad that she is fused to the couch. She is fused with the nylon fibers of the couch. Paramedics show up, EMTs show up. They try cutting her off of the couch to move her to the hospital. Upon removal from the couch, she ended up passing away. Okay. So again, it's not that this is a choice. It could be things like depression. It could be, a combination of paralysis, something like that. It's just so important. I'm really trying to hound to you guys. So important that you guys are just checking your patients and asking like, hey, anything itchy? Do you want me to take a look at anything? Okay. Because again, moral of the story here, 100% preventable. Okay. All right. So itching, also known as pruritus. Pruritus is also known as itching. Okay. This is the most common symptom of primary skin disorders. Now, what I want to kind of talk about itching here, this is carried by unmyelinated C nerves. So let's do a little bit of review. Small C's. Small C nerve endings carry what kind of signals? New one that we're introducing here is itching. What else?
Dull and achy.
Nice. Dull, achy, burning, radiating, cramping. Now, when you have small C nerves activating, is it poorly localized or well localized?
Poorly localized?
Okay. In opposition to small C's, you'll have large A's. Large A's now. What kind of signals do large A's carry? Sharp. Sure. What else? Let's say sharp pain.
Well localized?
It's well localized. What other kind of signals? Think about your gait control theory. How do you stop muscle soreness?
Heat.
Heat. / cold. So I'm going to say temperature. Okay. Vibration. Pressure. There's a new one here. There's a new one that we're adding to the list. How do you alleviate an itch? And please do not say you itch an itch. That makes no sense. What do you do to alleviate an itch?
Scratch it?
Yep. So that's the new ones that we're adding there. Okay, an itch is transmitted by the small C's. How do you get your small C's to be quiet? You can scratch it. That's also carried by your large A's. Okay, so those are the new ones. All right. So some random skin disorders. I'm going to tell you, don't even worry about this here. I'll tell you when to start writing stuff down. Okay. Psoriasis is freaking weird. If somebody has psoriasis, they produce skin 10 times faster than the average person. They're straight up Wolverine, but with a skin condition. Okay. In fact, they grow skin so quickly that they don't have time to mature properly. That's what these patches kind of end up developing. So that's just unmatured skin cells. Acne. Anybody remember how fun prom was? All right, so some infections here. A couple of my favorite words show up in this. I just think that they just sound so funny. First up, folliculitis. What is inflamed? What is infected?
The follicle.
Follicle. And what do we call it when a hair follicle gets inflamed?
Ingrown hair?
It's an ingrown, yeah, ingrown hair. Okay. Now, when that ingrown hair starts to begin to collect pus, it becomes a furuncle. Not to be confused with your fun uncle, i.e. a funkle, but a furuncle. These are just like so fun to say. Now, if you have all of your furuncles and you gather them into one place, you get a carbuncle. Multiple furuncles. It's kind of fun. So right there, that's a furuncle. Other fun words include frunk. Do you guys know what a frunk is? Okay. One day, when you guys become nurses and you make more money than I do, and you buy your first Tesla, Teslas come equipped with a frunk, i.e. a trunk in the front, because they don't have an engine.
How am I in the car business and never heard that term before?
Never heard of a frunk? Oh man, what would you call that? Hood cabin hood engine bay thing?
We still just call it they still call it a trunk. It's weird. Or there's like a weird British word for it too, I think, that I've heard some customers say with Porsches and stuff, but I've never heard that.
Oh, the boot?
Yes, it's a boot. Thank
Uh,
you.
No. This is America. We call it the frunk here. I think one of the best pranks I saw in a mechanic was like this guy has a Tesla and it's just like, man, I don't know what's going on. It's not working well. Like there's no power in the drive. Drives the Tesla to the dealership. They open up the frunk and they see a little hamster spinning on a wheel. It's just so cute. All right, herpes. Yay. Chickenpox and shingles. Don't get them. All right, fungal infections. Here, you should probably know the fungal infections, but only in terms of the location. So think about it like if I ask you, patient has tinea capitis. Tinea means fungal infection, and then capitis, think of it like the cap, i.e. the scalp. Okay, so I'm just going to ask you, hey, patient has a fungal infection at the scalp. What would it be? Tinea capitis. Okay, tinea pedis, that's your foot. Ped, to walk. Okay. Tinea corporis is ringworm. Okay. Tinea curious. This is the way I remember this. Do you ever get curious on why it itches down there? Chalk itch. And tinea inguinum, I got nothing. Sorry. All right. Candidiasis. I'm going to leave that for another teacher. Scleroderma, don't need to take any notes on this. I just find it extremely fascinating and kind of sad. The issue with scleroderma is that the skin and all of your linings become super tight. So your skin becomes super tight. The linings around your organs, your lungs, your heart becomes super, super tight, taut. It's pretty fatal with a crazy mortality rate. Again, you don't need to take notes on that. But take, for example, here, take a look at the picture of this hand. Compare that to the back of your hand. What is this person missing that you have? Come on, I can't be the only old fogey here.
Like the creases and the wrinkles?
Yeah. Where are the creases? Where are the wrinkles? That's how tight the skin becomes. Now, I want you to imagine that around your lungs, around your heart, around your mouth. Okay. That's scleroderma. Moly, moly, moly. Okay, malignant melanoma, super serious stuff. Why? Because if you have malignant melanoma, hey, how much distance do you have between the top of your skin and a blood vessel? Not much. Super aggressive, easy to metastasize. Okay, tanning beds. You live in Colorado now. Don't waste your money. Okay, talking about burns. Okay. So with burns, I'm going to tell you your burns, these are going to be on the final as well. I think you have one question on your quiz about it. So burns. Burns are very similar to decubitus ulcers. Okay, they come in different, not stages, but degrees here. What you're seeing in red are the nursing diagnoses. You're going to learn these in quarter 2, so I'm not going to be using them. Okay, again, I'm going to be describing them and asking them in terms of degrees. Now, burns are kind of like ulcers, except now it's top down. This is what you guys were thinking was decubitus ulcers. Okay, so in a 1st degree burn, what layer of skin is affected if it's top down?
The epidermis.
Epidermis, absolutely. 2nd degree, it's going to be epi, and now your dermis. 3rd degree, your epidermis, your dermis, sub-Q, and finally your 4th degree. That's your epi, your dermis, sub-Q, and now muscle/bone. Okay. So I want you guys to think, give me an example. Actually, let me back up, try here. You see how we have 4 degrees here? That's what I'll be referencing. If you have an interest in the burn unit or working with burn victims, if you specialize, there can be up to 7 degrees. Okay. So just bigger world out there. So I want you guys to think, give me an example of a burn that only affects your epidermis.
Sunburn.
Sunburn, or a really good your mama joke. Absolutely. Okay. So according to this here, sunburn affects your epidermis. Would you feel pain with a 1st degree burn?
I feel like you do. Just based off of personal experience.
Life experience, right? So this is what I'm trying to talk about. Like, this is kind of hard to separate like theory from like anecdotal evidence. So think about the last time you got sunburned. Did you find out you got sunburned right at the burn or the day after when you took a shower?
Day after.
Mm-hmm. What I'm getting at is when you get a sunburn, you don't actually know that you're getting burnt. When you become aware that you've been burned, that's when you've started the healing process. So in theory, getting a sunburn doesn't hurt. Healing from a sunburn, that's when it hurts. Okay. So you have to also kind of be careful here. These examples are not just restricted to these degrees. Take, for example, this is a pretty bad sunburn. Would you agree? This girl is going to have a terrible series of showers for the next couple of weeks. You can get sunburned so bad that it can be a 3rd degree burn. Okay. So again, just saying, like, these examples here, be kind of loose with it. They're not set in stone. There was unfortunately a case, I believe in Arizona. I don't know. I believe it was Arizona. This facility was a child daycare facility. This kid was acting up. So what did they do? They put the kid outside in the Arizona sun and forgot about the kid for 18 hours. By the time they found this poor kid, there was pustules. So can you get a 3rd-degree burn? Absolutely, from the sun. Absolutely. I'm saying loose with it. Typical sunburns are usually only 1st degree. Okay. So what would be an example of something that causes a 2nd-degree burn? Notice here we're affecting the dermis. Dermis has blood vessels, so this would cause inflammation. This would cause swelling. What kind of burn would cause swelling?
Like something from the oven that causes a blister.
Yeah, so I'm going to say like heat, something that causes a blister. Oven, baking cookies. You forgot which pan was a hot pan? Okay, ladies, how about them hair curlers? Oh dear God, is that a barbaric torture device? Okay, like I'm thankful I don't have enough hair to straighten and or curl. It is how it is. That's the way I live my life. Now, heat. Again, can somebody suffer, like get trapped in a house fire and get 3rd-degree burns from heat? Absolutely. Typically saying quick exposure to heat causes a blister, that's your 2nd-degree burn. Okay. 3rd-degree burn. The example here I'll give to you guys is chemical. Okay, chemical burns. Now, this is a little bit of kind of, I don't know, dark PSA. Chemical burns, thankfully, are not very popular here in the US, but they are kind of gaining traction. They're a lot more popular in the UK and kind of the Middle East. 2 lovers start dating, they break up, one lover becomes scorned, comes back at their ex by throwing acid or a strong base in their face. This is going to cause a 3rd-degree burn. These strong chemicals will eat through the top, the epidermis, the dermis, and into the sub-Q. The particularly shitty thing about chemical burns, unless you know what it is, you can't stop it. If it's an acid, for example, and you put water on there, you're going to turn it from a chemical burn and cause it to become a fire or a heat burn. Chemical burns are just nasty, nasty stuff, and you can buy this shit at Home Depot or even Walmart. Okay. Be careful out there. 4th-degree burn. Now, again, fire can obviously cause a 4th-degree burn. 4th-degree burns can happen in fractions of a second. Some people, I'll just straight up tell you, electricity. We're talking about people working with transformers and power lines where the electricity arcs so quickly that it actually sears the nerve shut before they can actually transmit a signal. If you want some good nightmare fuel, if your Halloween was not spooky enough, I dare you, don't actually do it if you're eating breakfast, but I dare you to Google image an electrical 4th-degree burn. Again, that's up to you. That's your browser history. Okay. What's insane about it is it happens so quick that these people don't even know that they're burned immediately. The only way that they know something is wrong is they can smell themselves cooking. Okay. Well, yeah. There's gaping loose skin. Like it's crazy. Oh, like the electric chair. Electric chair was a little bit different how they try to do it, but yeah, you can kind of see these burns on the scalp, especially if there was a short. They used to put a wet sponge underneath the helmet to help conduct electricity to go more into the body rather than kind of just burning the tissue. Yeah, I don't know. That's another weird fascination of mine is like weird ancient medieval torture devices. But yeah. Okay. So this person here was the unfortunate victim of a house fire. We're looking at 2nd and 3rd degrees on the face. All right. So a little bit of a dark PSA. This is as dark as I'm going to get here. Okay. Nursing is not an easy career, guys. You guys know this. I try to keep things light, but there's a fucking messed up world out there. Okay. Case in point, my sister, she is a social worker in Fort Collins. First week on the job, she gets called to the hospital for an SBI, serious bodily injury. She shows up to the hospital. The infant is in the burn unit. The infant has 2nd and 3rd degree burns over 80% of its body. When she shows up she's walking through the waiting room, she sees the parents. The mother is sitting on the chair playing Candy Crush on her phone. And the dad is screaming at the police officer for not doing his job or something like that. As nurses, you are going to be looking at the face of pure evil. Okay. What ended up happening was these parents drew a bath for their baby, but they didn't test the water's temperature. It was too hot. Baby was put in there. Baby started kicking and screaming. They put the baby back in there thinking it was being disorderly. Okay. This is a dark field. And sometimes you're going to have to be able to look straight up evil in the face and still maintain some sort of air of professionalism. People are fucked up. Okay. But remember, you're not here for those parents. It's not your job to punish those parents. You're here for that baby, for that infant. Okay. Little bit of light out of the darkness here. Y'all, this is an exciting time for you to be a nurse. An absolute exciting time for you to be a nurse. Think about, for example, the vaccine, the COVID vaccine. How fast did that get developed? That's amazing. At no other time in history have we ever seen technology and advances move faster than current practice. Okay. So take, for example, this is not exactly it, but down in Brazil, they were running out of bandages for burn victims. What they ended up doing was they used tilapia skin. They grew these fish in a very septic environment, harvested the skin, and the skin has 7 times the amount of collagen that human skin does. That means these bandages could be applied to these wounds and left on there for a week. Didn't need to be changed, because every time you change a bandage on something like this, you're removing healthy skin. And how amazing is that? Just like, hey, yeah, you want to try some fish? Okay. So different kind of burns here. Oh, I forgot to get this one here. My EMTs, my paramedics, you may have heard whispers of this on the horizon. I believe it's going to start being rolled out pretty soon here. They're doing, I think, final FDA testing on it. Nope. They have spray on skin now. They have spray on skin for wounds, injuries out in the field. When do you see what happens when they take it off of a patient? It's absolutely insane. But this kind of webbing here only sticks to necrotic tissue. It only sits on healthy living tissue. We're going to be able to heal injuries so quickly. This is going to change how you guys practice, especially if you want to be working in the ED. Okay. Another personal thing that I think is absolutely amazing, and regardless of legal implications or whatever. Take a look at this kid here. This kid suffered severe burns, and we treated this kid using stem cell therapy. Now, we're not talking about stem cells harvested from aborted fetuses, not that kind of thing. You pee out stem cells. Did you know that? You straight up pee away stem cells every day. You have stem cells all over your body. The hard part is either harvesting them and then growing them. This kid here with this kind of treatment, think about how much of an impact you're going to have on this kid's life. This kid's not going to grow up with body image issues. This kid's not going to wonder, why am I different? You get to give a kid a chance to be a kid. Isn't that freaking awesome? Anybody notice though? It's not quite perfect yet. What's the kid missing?
A belly button.
Yep.
There's
And
no nipples either.
yeah, I don't know about you, but they're kind of useless for me anyhow. Like, I don't know. So the light at the end of the tunnel here for you guys, don't ever stop learning. Don't ever stop learning when you're a nurse. Okay. Always push yourselves to keep learning something new, something that's going on. The day you don't learn anything when you work a shift is the day you need to quit because you're burnt out. Okay. Push yourselves to constantly keep learning, learn all that you can because you don't know how much of an impact you can have on somebody's life. Congrats, guys. We are done with Patho. It's been a roller coaster. I'm gonna miss you. I'll tell you guys, like, Lita, God, just take and take and take. I can't just say that I appreciate you without you asking for something. God.
I'm scared for the coming semesters because I feel like you set the expectation really high for teaching, and we all love you so much that I'm nervous for the following semesters.
Sorry,
I'm gonna
guys.
really miss you.
Yeah, this is the shitty thing about like the quarter system is I get nesting syndrome every 3 months. Like I get so attached to get to know you guys, not just your names, right? But like to get to know you, like your life, and then I gotta say goodbye. But hey, because I'm also going through nursing school, hit me up. You guys got questions in farm? I'm gonna do a Q2 primer on Monday's online class, i.e., what should you do to prepare for Q2? So after our kick-ass review, we'll talk about Q2. Kind of help point you guys in the right direction, right? I'm currently in Q3, so I'll be starting MedSurg 1. So if you guys need help or anything like that, need study tips, I've been tutoring, not tutoring, but I've been helping out like other students with dosage and things like that too. That's one of the reasons why I kind of wanted to jump into this program to kind of be able to empathize a little bit more with my students, kind of know what you're going through, so I can kind of help you with that. Like I said, it's almost like I care, almost. But yeah, don't be a stranger just because you guys aren't in my class anymore. Just swing on by, say hi. After I am done posting your final grades, I am no longer legally responsible for you. So if you as consenting adults randomly bump into me while I'm enjoying a beer at a brewery.
I was just about to ask, like, so do you want to go get a beer after this quarter's done with all of us, or?
Okay, so let's see, you guys take your final on Tuesday, right? And we're gonna have your final start at 9. I have to give a final in the afternoon, but so this is just me thinking out loud because I am not allowed to legally plan anything. Just thinking out loud. You guys take your final from 9 to 11. Usually most people are done before the 11, but I just to be safe, I should be done grading by 11:30. I have to give another final at 12:30. So between 11:30 and 12:30, I could probably swing down to Milk Market and grab a beer. Just thinking out loud. Yeah, and you're more than welcome if you guys want to add me to the group chat. Again, I'm not going to impose on you or anything like that. But yeah, just before I have to give another final. All right. So talking about the final. Okay. So that endocrine stuff still makes up 50%. Still working on writing it, so this is going to be, flexible stuff. You're looking at give or take about 30 questions. Okay. And 1 essay. I might respond in memes and GIFs as well. Okay. Now, in terms of this essay here, because I kind of like you guys. Two options. It could be compare diabetes type 1 versus type 2. We're talking about insulin relationship. We're talking about age of onset. Yeah, I know. But Lita, at least it's not an actual essay if I choose this one. It's just bullet points in a table. Just for you, Lita, you get to use full sentences. Age of onset, treatment, symptoms. Okay. Or I might ask you to compare Graves versus Hashimoto's, where we're looking at the cause. Like I'm actually, if I choose this one here, it's going to be a little bit more of a lengthy discussion of like how does Graves happen versus Hashimoto's. They're both autoimmune disorders, but kind of act out differently. Symptoms, treatment. Yeah. Somewhere around there. Okay. So it's going to be one of those two ones. I'm not entirely sure yet. Okay. For your cumulative essay, or let me say cumulative part. Okay, you're still looking at give or take about 30 questions. And I think I might change this one up here. You might have two, I'm going to say shorter essays. Instead of like one big essay, like two shorter ones, like we're talking about like maybe 4 lines of response instead of 8. Okay. I'm not going to tell you what they are yet because I don't know, but I'll probably figure something out when we hit the practice exam on Monday. Okay. It will not be an essay prompt that you've had before. Okay, so it'll be something new. Now, in terms of the cumulative stuff, oh, by golly, take a look at your patho binder. Is there a lot of shit in there or what? Okay. Now I'm asking you to go over all of that in a week. No, that's unrealistic. Okay. I love patho, but it's probably not on the top of your to-do list. So a little bit of this is just a peep behind the curtains here. Exam 1, you had about this much information, right? Exam 2, 3, 4, 5 was a little bit shorter. So this is just like a little bit of insight in terms of teaching. Each exam took you, give or take, about 75 minutes. Okay. If I'm going to test you over all of this information for exam 6, your final, that would be nearly off the charts. That'd be a 6-hour exam. That's impossible. Okay. Instead, what's going to happen is I'm going to take small parts from each one. To make your final, because your final is, yes, a little bit longer, but all of these parts have to add up to the final. Okay. So what I'm trying to say here is when you're studying for these different topics, you're looking at the big picture stuff. Okay. Do you think I'm going to ask you what IgA does? But do you think I'm probably going to care about pressures and fluid balance? Absolutely. Okay. Now, because it's a lot of information, it's kind of daunting, not going to lie. Okay. And you know, I kind of want you to do well. Go to your modules. Okay, if you go to the modules in the course, scroll down all the way to the bottom. Yep, well, I'm in the wrong course. Psych. How about I go to your guys' cohort and actually show you? Modules. All the way at the bottom. Do your eyes deceive you? Oh, it's not going to do a preview? Oh, there we go. Doth your eyes deceive you? Is that a topics list to help you narrow down all of the shit we've covered throughout this quarter? Oh, by God, yes. Including on the second page, the musculoskeletal stuff that we talked about. Okay. So osteomyelitis, osteoporosis, inflammatory, non-inflammatory, ulcers, fungal infections, and burns. So hopefully this helps you guys narrow down your studying a little bit. Okay. Be careful. Some of these bullet points might be a little deceiving. 6 hallmarks of cancer. That means there's 6 subpoints, right? Lines of defense, first, second, and third line of defense. Do you think you could describe to me the second line of defense, the inflammatory system, in 6 bullet points? Probably a little bit more complicated than that, yeah? So what I'm getting at is just because it's a single bullet point, don't underestimate it. Some can be beefier than others. But I mean, like, look at this one. What cell does HIV virus infect? It's one cell, it's one bullet point. CD4 cells, done. Okay. So use this to help kind of monitor, to help trim down what you need to do. I'll only be asking questions from this list here. Heads up, I am not yelling at you. I don't like to write in all caps, but I'm just drawing attention to that. Endocrine, fair game. Okay, that chart, hormone, what does it do? What happens if you have too much? What happens when you have too little? Feel a little better? Just a little bit? It's just as much as I'm proud of you. All right, guys, that's what I have for you. Final questions, preguntas? I don't know, Maddie. I have no idea. Oh shit, I was supposed to do an exam debrief. Well, honestly, the averages were so good that, yeah. Oh, I did end up dropping a question. I dropped the what is the most important lab value in determining renal function? That question there, I actually ended up dropping it because I never give you a right answer. Sorry. It should be urine creatinine. But whatever you put on that, you got full points for it. That was the only question I really dropped. There wasn't any other like glaring things. But if you do have questions about any of those questions, just shoot me an email, screenshot it, shoot me an email, and I'll write you up an explanation, or we can talk or resume. Totally forgot about that, Lita. Sorry. Wow, Lita, you're just like hounding me to do my job. What's up with that? Yeah. So, y'all, I hope you had a little bit of fun in Patho. It's been a good quarter. Really thankful that you guys were the morning cohort. So, just generally on my behalf, I'm just saying I appreciate y'all. You're gonna do good. All right. Well, I'll hang out if anybody has questions. If not, go get yourselves a nice little pumpkin spice latte. Enjoy yourself a little bit.
A question that is kind of silly, but I'm wondering.
No,
if
no,
you
no, no.
I always confuse the parasympathetic and the sympathetic nervous system. I've done it for like all of the years that I've ever known about them existing. Is there like a trick to remembering? Because I know what they do, but I just always think sympathetic is rest and digest and parasympathetic is fight and flight. And I don't know how to.
I got you. I used to have the same problem too, especially when I was trying to study for med school, like the MCAT. Plot twist, didn't work out. This is your sympathetic nervous system. So as you were saying, parasympathetic is rest and digest. Your sympathetic is fight/flight. So the way I remember this, when you rest, you need a pillow. Ta-da.
Yes, no, that's great. I just always, because I had the whole process right in my head yesterday on the exam for that one question. I just mixed up sympathetic and parasympathetic.
No worries. I used to do that too. So yeah, in order to rest, you need a pillow.
Thank you.
There was one question on the exam. Well, let me find it. It said, which of the following substances are filtered into the urine? It said sodium and chlorine. Did you mean to put chloride?
Yeah.
Okay, sorry, because that confused me because I was like, ooh, maybe he did that on purpose, and I don't know.
I gotcha.
So that was just a
Well,
me thing.
because you brought it up, that is my mistake. So chlorine, chloride, same thing. It's just the different number of like electrons attached to it, basically. If you got that one wrong, I'll drop it.
I did get it wrong. I don't know why I'm typing it.
Yeah, no worries. I'll drop that for the class there because yeah, absolutely. I didn't see that. Thank you. So I can
Okay,
change
because
that.
I looked at it and I was like, I don't know, maybe I'm overthinking this. I was like, but maybe he did that to like trick us, and I don't know. I probably just way overthought it.
Sorry, I've turned you into a little paranoid squirrel.
Hey, when are you gonna send us those pictures we took yesterday?
Oh, in an email today, probably, because I need to also send out the calendar that I wrote up on the board yesterday. So you'll see an email from me today. The only unfortunate thing is I don't know when quite yet, because after this class, I got a faculty meeting I need to attend. Thank God it's my last one. Like they made me a chair of a committee, and I don't know why. But after that, then I got to teach. So you'll see it today, this afternoon, if I can slack off a little bit, or in the evening later tonight, if I don't have time to. So real soon, I promise. Chlorine. Who the hell put chlorine? Oop, one second. But yeah, absolutely, I will be sending those your way. Yeah, no
Yeah, I was like
problem.
thinking about it on the exam. I was like, we definitely don't pee chlorine. So
It would be so clean if we did. Or I can't spell it, but yeah, I'll change it so that way you'll see your score change here in a little bit. Madeline, it's the question about what do we filter? It's supposed to be sodium and chloride. Apparently I wrote chlorine. My bad. So whatever you put for that one, I'm gonna end up dropping it. And I'm gonna be doing that now before I forget. No problem. No problem at all.